welcome to our February 9th Project Echo Dementia session. We will kind of go through our usual protocol of some opening notes and reminders. If it's your first time with us, we would love to meet you. So go ahead and put your contact info into the chat if you would. And then also thrilled that we have Dr. Veronika Zantop here, consult liaison psychiatrist at Swedish, to talk about non-pharmacological management of behavioral and neuropsychiatric symptoms in dementia. And then we do not have a case today, but we do have, I'm sure, plenty to discuss. And worst case scenario, we can go a little longer with the didactic and give you the gift of time, but I'm sure there's lots to talk about. So, all right, let me scroll through these. Looks like everybody is named. I don't see any phone numbers or other things, so we can skip that first part there. We are all masters now at muting our microphones, not always unmuting, but we're getting there. If you are able to, it's always great to be able to see your lovely faces if you can turn your video on, but we also understand that you may not be in a place or position to do so. And if there are multiple of you in your location, if you could put everyone's name in the chat, that just helps with CE and other kind of attendance record keeping. If you are a UW faculty, staff, or student, here is the new process for obtaining CME, and there's the phone number. I believe that's also in the email that you get, so that information is there. If you are outside of the UW system, we'll just do it the way we've always done it. So hence the importance of all your contact information. All right, and then just a reminder, some other CME accredited series that are offered that may be of assistance for your practice around traumatic brain injury, addictions, and psychiatry, or the telebehavioral health training series. Similar, the telephone consultation for thorny issues like pain management, and then the UW Telepain series. Also, a repository of fantastic information is the UW Psychiatry Grand Rounds Archive. I would say the same about the Neurology Archive too. We can throw that up there sometime. Many of you have already completed the Healthcare Professional Survey from the Dementia Action Collaborative. If you haven't, we would love your input. This is a chance to clarify the picture of the state of dementia care here in Washington and help iterate programs like this to make sure we are doing the job we need to be doing, taking care of people and family living with dementia. So there's your QR code. Some echo reminders. We don't have a case today, but in any clinical discussions, we will do our best to protect PHI. We can always edit it out afterwards, but it's better just to be proactive about that. All of our sessions are recorded, available on the website, including materials, resources, and slides. And then we always value your feedback and input as we try to make this the best possible program for you and the people you serve. So we'll have a 1-minute survey. Here's the next set of didactics that are coming up. So later this month, we'll have our own Dr. Eisenberg talking about dementia prevention and modifiable risk factors, all the way through the end of our kind of 10-session essentials with our own Dr. Pattison talking about palliative care and hospice. Cases. We love them. They are always so appreciated, and such a critical part of our learning. So please do reach out with your cases to either me or Nancy or Sammy. No case too small, simple, complicated. We all have kind of the same questions, I think. So it's a great learning opportunity. And we send you this very detailed list of recommendations that you can then take back to your practice. We are accredited for CME. We don't have any disclosures, either our speaker or our planning committee. Here's our hub team. Here are all of you out across our wonderful state of Washington. And we are actively recruiting other providers to join this fantastic community with an emphasis on FQHCs, tribal clinics, really trying to reach out to people who need this kind of community. If you have colleagues that you want to refer, please do. We'd love to have them. And with that, I will turn it over to Dr. Veronika Zantop to talk about non-pharmacological management of behavioral and neuropsychiatric symptoms in dementia. I'm going to stop sharing my screen, and Dr. Zantop, feel free to take it away. And I think you are still muted. Screens look great, or
All
your
right,
slides look
perfect.
great. Perfect. There you go.
Okay. Wonderful. Thanks so much for having me. So my name is Veronica, and I've been a consult liaison psychiatrist, first at UW in Harborview, where I trained in psychiatry, and then for the past 15, actually 16 years now at Swedish Medical Center. And we've expanded to 5 different sites. So we have Issaquah, Cherry Hill, First Hill, Ballard, Edmonds, and are now expanding into Everett. So soon to be 6 different hospitals where we see consultations. And what I was mentioning before is that when I started about 16 years ago, maybe 20% of the patients that we were consulted on were patients with dementia and behavioral disturbances. And I would say now it's about 70% of patients that we see are patients with dementia with behavioral issues. So it's something that's pretty prescient for the time. Um, okay, now I just need to figure out how to move my slides, excuse me. There we go. So these are the objectives for a very short presentation. Um, but basically just I'm going to talk about the consequences of not treating behavioral issues, learning more about what defines behavioral issues and why they happen, why pharmacological strategies are not always effective, and why behavioral strategies are first line, and then review the range of interventions to target individuals, their environment, and their caregivers. What we've seen in the hospital here is that management of behavioral issues for patients with dementia and just patients in general. So a lot of these things I'll talk about apply to patients with agitation or psychosis generally, not just patients with dementia as well. But that it's very, very stressful, puts a big strain on the patient who's in the hospital, healthcare workers, physicians, ancillary care workers, and the system at large. We have some patients in the hospital that have been here for almost a year now with dementia and behavioral disturbances and have not been able to get placed. So it's a big burden for everyone. To start, dementia is defined as a pandemic by the World Health Organization, with the expectation that we're going to have about 16 million people suffering from dementia, and about 115 million people worldwide by the year 2050. Neuropsychiatric and behavioral issues are the core features of dementia, in addition to cognitive issues. And if untreated, what they found is that these behavioral issues lead to a very poor quality of life for the patient, um, a rapid disease progression, so not only increased morbidity, but increased mortality as well. And then earlier nursing home placement, psychiatric admissions, which we're seeing quite a bit, and which may not be appropriate for patients actually, and much higher overall healthcare utilization and costs. So non-cognitive symptoms associated with dementia include these neuropsychiatric or psychological symptoms, and then behavioral symptoms, or manifestations of a combination of the cognitive impairment that patients experience and also the underlying psychiatric symptoms. So, for example, the psychological symptoms that we see frequently encompass depression and apathy, which especially happens earlier in dementia, and later agitation, delusions, and hallucinations. In terms of behavioral issues that we see quite a bit, repetitive vocalizations, shadowing, wandering, and argumentativeness, refusing care, and even violence towards healthcare providers in the hospital. Symptoms frequently change with illness severity, or even in the hospital setting. You're more likely with mild cognitive impairment to see more depression or apathy, which is marked by decreased motivation for more than 4 weeks, and two of the following, which is decrease in goal directed behavior and cognitive actions or in emotional expression. And then medium to severe, which is really a mini mental status exam of less than 20, you see more of the delusions and hallucinations as well as aggression. Um, and this includes emotional distress, psychomotor activity, disinhibition, things that I'd mentioned before as well. And this is typically what we see here in the hospital setting, is when patients start to become aggressive with caregivers or are not compliant with care. Psychiatrists are most frequently consulted for agitation, which is a broad term. To better understand agitation, you can break it down into three different categories. There's physical agitation, where patients have psychomotor agitation or hitting, biting, pushing, striking out, etc. Verbal agitation, where patients are screaming, making threats, or doing other or engaged in other behaviors to get attention. And then there's kind of passive agitation, including withdrawing, hand wringing, blank stares, non-engagement. Very briefly, you can see that there are different symptoms that define particular types of dementia. So vascular dementia, for example, most likely presents with depression, Lewy body with hallucinations. And the hallucinations for Lewy body dementia are not always scary hallucinations or frightening to patients. In fact, they can be nice hallucinations. I would say the most recent patient I saw was seeing cats in her room, small cats, and was quite pleased by that, actually. Um, Frontotemporal dementia is a loss of executive control, is most prominent. So symptoms of disinhibition, kind of social inappropriateness, as well as apathy or wandering. So really non-pharmacologic treatment is considered first line for managing behaviors and agitation. I would say for some of the neuropsychiatric manifestations, like the depression or the apathy or the actual hallucinations and other psychotic symptoms, there is a role for particular well-targeted medications. For behavioral issues generally, including agitation, wandering, some of these other issues, the data really does not show that our use of medications, which are typically off-label antipsychotic medications, are particularly effective in comparison to placebo. Some studies show a modest effect. Um, in addition, the medications that we use, in particular the antipsychotics, have additional risks for patients. So they have higher risk of metabolic symptoms, falls, increased risk of confusion. And then they know with antipsychotic medications in particular, studies have shown that there's an increased risk of all-cause mortality, and that's something that we have to talk to patients about. It's a black box warning that patients with dementia who are treated with antipsychotics have a higher mortality risk from cardiovascular and neurologic events. So the medications, which is to say that some medications can be effective in treating particularly well kind of described symptoms, but in general, I would say that we overuse the antipsychotic medications for behavioral control and also just to sedate patients sometimes. So factors that increase the risk of behavioral issues, I'm sure everyone is aware of. What we see in the hospital a lot is medical issues and patients who come in with superimposed delirium on top of dementia, which causes agitation or psychosis. Delirium has lots of different causes. What we typically want to rule out is infections, so urinary tract infections or other kinds of infections. Medication side effects. So frequently older patients are on a lot of different medications that have anticholinergic effects, which can cause confusion, or they're treated with anti-anxiety medications that have further anticholinergic effects. So looking at all the medications to see, where there's polypharmacy or where there's medication interactions, whether the medications are too high, whether or not they're being prescribed high risk medications like benzodiazepines, is really, really important in helping manage behavior. Other things that increase risks are pain. So that's something that we always ask about in a hospital setting or try to determine pain and discomfort, I would say. Sleep disruptions, something else that's hard in the hospital because at night, the hospital, it's like the daytime. Nurses are going in and out of rooms. The lights are on. They're things are beeping all over the place. And so sleep disruption happens quite a bit. Also, shades are drawn typically during the day, so rooms can be dark, and patients are not particularly engaged or alert during the day, which then affects their sleep wake cycles. Poor nutrition or not eating. Constipation is something that we see a lot, which causes discomfort and can also lead to behavioral issues and should be treated. And then poor vision or anything that would impair a patient's inability to communicate effectively, like dentures, hearing aids, glasses, things like that. Being in a new and unfamiliar environment is a big risk factor that we see a lot in the hospital. So those are some of the risk factors. And then caregiver distress is also a big risk factor. And so that's something that I'll address later too. So usually behavioral issues are really caused by a confluence of factors, both internal and external. And so it behooves, you know, us as consult physicians and other providers to really get a sense for what all the factors at play are and to see which ones are modifiable. One article that I was looking at, and I liked how they conceptualize this, but when behavioral issues are going on, in addition to looking at the risk factors and trying to figure out if there's anything going on that can be modified, are asking questions like, does the patient have any unmet needs? Is there anything that they're trying to express or that they need? Are we inadvertently reinforcing issues? And I think that happens in the hospital all the time. So when patients are screaming, then providers will come, nursing staff will come into the room to see what's going on, and then that kind of perpetuates that as a way of getting what patients need. And then mismatches between the patient's environment and what their actual abilities are. So abilities to follow cues, to know what's going on, etc. So those are things that are important for us to ask ourselves: are any of these factors in play with patients? In terms of specific strategies, these can be broken down into different categories. And I imagine this is kind of an area of expertise for people listening. But what I think is always really helpful, number one, is just to consider factors that are affecting the individual patient, and then what actually is helpful for patients and what is not. And then what are environmental factors that are affecting the patient, and how can those be modified or changed? So individual patients, what they found is, and this is not surprising, but what's helpful is if providers are keeping their tone calm, and this doesn't always happen, that communication is very simple, that sometimes physical cues are used in addition to verbal cues. Acknowledging patients' concerns, empathizing with distress, and reassuring patients can really, really go a long way. And then providing patients with routines, for example, so that they know what to expect day by day is really helpful. What we try to do here is, have the same sitter, try to have the same nursing staff, and try to be very consistent in terms of when patients get medications, when they get their lunch, when they get their dinner, when they get a bath, things like that. Things involving their environment, so either over or under stimulation, so assessing for that, really important. Really trying to maintain day and night semblance, so putting up all the curtains or opening up the curtains during the day to make sure that it's clear that it's daytime, and then closing them at night, really trying to avoid nighttime intrusions or unnecessary interventions of any kind. Um, the other thing that helps is removing objects that are distracting to patients. So all the different tubes and monitors, or whatever it is that you can do to simplify the environment that they're in. Um, and then also the objects that you can add to the environment. So kind of calming sensory stimuli Yeah, they have little fidget toys for patients here, or squeezy balls, or something that where patients can use kind of calming sensory stimuli for agitation or anxiety. And then increasing daytime activity. So trying to make sure patients are doing things during the day. And, that can then lead to better sleep at night as well, and keep them occupied during the day with things that they enjoy doing. Um, the next slides really drill down even more into specific target categories for managing behavioral issues. Um, these are some resources for caregivers. And again, I talked a little bit about how it's really important for caregivers to have education and to understand what's going on with patients. Um, for I usually go over on time, so actually today I might go under, but I was not going to talk about this extensively just because of time considerations. Um, Communication, we've already talked about. One additional or a couple additional things that I found is, frequently when nursing staff come in or physicians come in, you're trying to get stuff done. And so we frequently do not allow patients enough time to express themselves or to kind of gather their wits about them, which can make people really agitated. So I will always go in the room, sit down, and just wait and see what they have to say rather than, asking too many demanding questions up front. Helping patients find words when they're struggling to express what they need. And again, just offering very simple choices. Um, in terms of the environment, a couple of other things is removing distractions, like we talked about, visual cues, so labeling things or putting arrows. And then what I find is really helpful in the hospital is familiarity. So putting up pictures of relatives or loved ones, or having people that the patient knows in the hospital. This doesn't always work. Sometimes it causes more agitation, but just creating an environment that's somewhat familiar, or easy to navigate. This is something that's overlooked a lot is caregivers. Caregiver burnout is huge, and caregiver distress can augment patient distress. Um, so really what we try to do in the hospital here, at least, is to encourage caregivers to engage with self-care and to get support, psychological support if needed, to really help them understand that the behaviors are not volitional. I think it's more easy for us to understand that and harder for loved ones to understand when they're, um, when their loved ones are suddenly acting in ways that are not kind, or not helpful. Um, the other thing we talk about is kind of relaxing our ideas about rules, so things don't have to be done in a particular way, that we can find workarounds and find different ways of doing things that work for the patient rather than for us. The other thing I see a lot, and I have probably done myself, is for patients who are delusional, or who are having hallucinations. I think um, you know, the desire is kind of to clarify things and to reassure patients that their delusions are not true. And arguing with patients is not particularly helpful, or trying to dissuade them, I think, from some of their delusions. I mean, delusions are marked by this is their particular reality. So working with this particular reality rather than trying to convince them that this is not actually true, or trying to counter their particular reality, can be helpful. In terms of particular tasks, so tasks that patients have to do, self-care tasks or ADL tasks, breaking things into simple tasks, using tactile cues at times and verbal cues, and creating structure and routine, again, like we talked about before. And then activities, and this is something that I'd mentioned, Swedish is working on with our PSAs that are frequently at the bedside. And traditionally, the PSAs here really don't interact with the patients. They will sit there and make sure patients don't get out of bed or fall, but otherwise don't interact with patients. And so there's a program right now really looking at training PSAs to be more engaged with patients and help implement a lot of these behavioral strategies. And so some of the activities that are recommended is tapping into previous interests. So we have I have a patient recently who was a painter, is up in her room drawing right now, which has made her a lot more calm. Um, Offer tasks that involve repetition, and then being aware that some of the symptoms are kind of lack of initiation, or not having the capacity to actually set up particular activities for yourself, and so having caregivers help set up particular activities and then help patients initiate those particular activities is really important, rather than assuming that patients will do that on their own. um, so that is it for my component.
Well, thank you very much for that wonderful overview. I really appreciate the focus on the care partner also, who has such a huge role in this. And I'm sure there's lots of um, points of discussion here, so I'm happy to open it up. If you want to stop sharing your screen, we can everyone will see each other,
Yes,
or
let
I can do
me.
that. There we go.
Perfect.
Um, Questions, discussions, things that people want to talk more about in more depth. We've got plenty of time. Nicole.
Hi there. That was really great discussion. Thank you so much. I was just curious, you had mentioned just the high number of patients with complex dementia behaviors that are in the hospital and can't be placed.
Hmm.
I'm just curious, is that because of lack of a decision maker, lack of financial resources to pay for care, or are there more issues that create that problem?
Yeah, that's such a good. I think it's a combination of all those things. I mean, we've certainly had patients, and I think this might be a COVID thing, and this is not based on any research, but just my own observations, is that a lot of adult family homes are understaffed and so can't manage patients that have behavioral issues as well as they used to. And so a lot of those patients just end up in the hospital. And then, we typically start antipsychotic medications with the hope that patients can then go back. Frequently, when they go back and are outside of this more structured setting, they again develop behavioral issues and end up back in the hospital. So that's really challenging. Or the other issues, patients with dementia who have psychosis or other psychiatric issues will get detained quite a bit and then be waiting for a bed for a long time, and there are very few beds available. So that's another issue that we face a lot. And then we've had a couple patients who have just become so violent and attacked caregivers that nobody wants to take them, and so they have very limited options for placement.
Thank you.
That was going to be one of my questions to you. Again, the emphasis on working with care partners who are often exhausted and don't have a lot of gas in the tank. Um, the things that make sense, like the ABC approach or the DICE approach, these other kind of behaviorally oriented things, take some training and they take some time. And one of the things that I hear frequently is, "We tried that, it didn't work. We tried that, it didn't work." And I mean, someone's threshold for trying it. Did you try it once? Did you try it for a week? Did you try it for 3 weeks? So I'm curious what your own kind of criteria are for when is, boy, we tried that and it's just not working and we need to think about something else.
Yeah, that's such a good question, and that's actually why I'm glad that to hear from other people as well. As a consult liaison psychiatrist, really we're called in to increase medications, and certainly talk. I mean, nurses are understaffed, they're really busy. They're not going to be able to go in to do all the behavioral assessments and kind of stuff. And that's, I think, why the PSAs are now so important. Like, who is actually at the bedside, who has the time, who could be trained in something like this. And so I think identifying that. I mean, for us, we can do that to a certain extent, but we see patients for 10, 15 minutes a day um, in the hospital. And I know this is beyond just in the hospital, but so that's actually a question that I don't have the answer to. I mean, I think, we course correct with medications quite a bit. And then also course correct with really basic things that we can talk to nursing staff about, like, limiting nighttime intrusions is huge, opening up windows. And frequently we rely on family at the bedside to do some of these interventions as well. And so I think, I mean, that's a really good question, I think, for the future too, is because we know that pharmacologic interventions are limited and can make things worse, but we don't really have an infrastructure in the hospital for something like this. How can we improve our infrastructure, and how can we improve, what's going on in the community, in terms of training and keeping patients out of institutions? Because I certainly don't think that patients are very well served in the hospital. I think things get worse, not better, for the most part. Um, maybe I shouldn't go as far as to say that, but it's certain. I mean, it's hard to manage patients in a hospital setting,
I saw some,
especially now.
yeah, I saw some heads nodding when you made that comment, so I don't think it's off base. Mhm.
And then patients get restrained, not infrequently, which is incredibly traumatic, I imagine. So yeah, so that I would love to hear from other people too. I don't, in terms of how long do you wait to make adjustments, and also what happens with something that's progressive like dementia, or even vascular dementia where things change very quickly. How do you adjust? How do you pivot in that sense? Or in the hospital, it's frequently hard to tell, is someone actually delirious or demented? And so are we doing everything that we can to address the delirium? Or is this really, their baseline in terms of dementia? So all those issues are also really challenging.
Yeah. And I know Karen Clay, I know you work with families a lot around non-pharmacological and, behavioral things, conceptualizing these as expressions of unmet need. So I'd love to get your impression, but I see Barack has his hand up, and I would love to hear what you got to say.
Karen first?
You want me to go first, or do you want to go
Sure,
first?
I was
I
I
don't.
was doing that thing where I was warning
Hmm.
Karen that I was going to ask her
Okay.
about that, but I was going to have
Okay.
you respond to give her some time to think about it. Here, a little peek behind the Zoom curtain here. Go for it.
Okay. Yeah, so thank you so much, Dr. Zantop. That was really, really good. And even though your talk is about non-pharmacologic approaches, um, I think that it's the pharmacologic question that ends up being the one that we all struggle with the most. I mean, because like I think especially for this like very kind of like sort of highly sort of engaged audience, like we know all those things, and but it's like so good to hear them, and you did such a beautiful job of summarizing them. But I think just because we have um, the the gift of so much time to talk about this topic, I was hoping we could sort of spend a little bit of time talking about pharmacologic approaches, and it might be helpful. Would you mind like sharing your screen again and going to your slide um, where on pharmacologic approaches? If that's really hard, don't worry about it because I can speak to it, but it's and don't worry, I didn't mean to have it be a whole long process to find it. It's um yeah, there it is. That it's that second bullet there. Medications show modest to no benefits. And I totally like acknowledge that that's like what the literature shows, and it's these are clearly not like I can remember 15 years ago when the sort of the newer sort of versions of antipsychotics came out, they were touted as being much more effective than this. But I think it's just like worth kind of like reflecting on this statement because people like because like every standard presentation will always say this, like these medications have never really been shown to be better than placebo, and yet like we all use them all the time. And so I think it's just like worth reflecting on kind of like what is the state of the science for this, and like why haven't they been shown to be beneficial, and if they really aren't beneficial, like why do we keep using them? And like we keep using them because we all see that they work when things are really severe and out of control. And so I think I kind of, so I wonder if it's just like it's somewhat of like a failing of the science, like people have not designed a good randomized control trial of somebody who is completely out of control with, their, severe agitation that is like, causing, themselves to be at risk to themselves and others. Like nobody has ever tested these medications in a randomized control trial in that setting because it would be unethical, because somebody is like, drastically in need of sedation. And that's mainly what these medications do. And they work in that way, and so, I mean, I think I just sort of am sort of like reflecting on how it may be time to sort of like think about moving past how we sort of like talk about antipsychotics, and sort of like moving past the concept of like they've never been shown to be better than placebo, partly because they've never been tested in the way that we use them, which is, and but I mean, so it's so important to acknowledge their overuse and their lack of efficacy for mild to moderate symptoms. But like really that's like different than they're not better than placebo, because I just feel like it's just such a weird thing that we keep saying they don't really work, and yet like we all use them all the time, like it's, and so I'm just sort of reflecting on that and wondered if you have any thoughts about it.
Yeah, I mean, I think I love that you said that. And I think because this talk was really about behavioral interventions,
Yeah.
I'm kind of looking at it from the other side, like why are medications not working as well as they should, or why are we using, or what are we using the medications for? I think you're absolutely right. And yeah, I think recently I've seen kind of the maybe unjudicious use just of antipsychotics across the line, and where patients are sometimes on 2 or 3 different antipsychotics, or on antipsychotics that's super high. So I think antipsychotics or antidepressant medications, or anti-anxiety medications, I think there's no question that those can be helpful, as long as someone is using them you know judiciously, kind of keeping track of what they're treating or what they're using for what. um, and especially, I think, with antipsychotic medications, tracking the side effects or potentially negative effects. But you're right. I mean, we use them all the time, and there is some benefit. I mean, absolutely. I think in terms of, is it sedation, or is it, actually treating underlying psychosis, or stabilizing mood, or whatever. Yes, I
Yeah,
agree.
and I personally think that it is like all sedation. Like I think that it, just because the psychosis of dementia can sometimes resemble the psychosis of schizophrenia. And so, I
Mhm.
mean, I think that's like, that was the kind of the rationale. And, when these second generation drugs first came along, it just sort of like it intuitively like, oh, maybe we really are gonna like change their delusions in the same way that we can with psychosis. And I don't know, it just feels different to me. And I'm not a psychiatrist, so I don't know. I'm sort of out on thin ice here. But to me, they really are mostly effective as sedating medicines. But like, good grief, like sometimes people really, really need to be sedated. And
Mhm.
these are probably, among the ways that we have of sedating somebody, these are probably the safest sort of options that we have. And so I think sort of thinking of them and talking about them in that way, I think is helpful, like especially like for the primary care sort of like audience that I sort of like talk to the most. I think like, people just need to hear that sort of message and, like stay away from benzodiazepines and sort of like don't use them for mild to moderate symptoms just because people are annoyed by the symptoms. But really, like when somebody is in extremis and they're at risk of, being hospitalized, they are better off being sedated in their adult family home than they are sort of being shipped off to the emergency room and getting admitted to the hospital. Which is like often the alternative. The alternative is either like you as the primary care doctor can prescribe a very low dose of an antipsychotic to somebody in an adult family home and probably do them a lot of good if their symptoms are severe.
Yeah. Yeah. Yep. I agree. Absolutely. And I think too, in the hospital, because of ease of administration, we'll use Zyprexa or olanzapine a lot. Whereas, ideally, Risperdal is better in terms of it has less anticholinergic activity, so, or Seroquel if you have more kind of Parkinsonian type symptoms. So there's, I think depending on what's going on, choosing a particular antipsychotic can be, and you're right. The alternative is benzodiazepines, or very anticholinergic medications like Benadryl or and when we have conversations with family a lot about, we're using these medications and they can increase mortality. And I would say probably 99% of the time, the family's like, if we can give my mom or dad some relief, I don't care, I mean, this is worse than dying, I mean, so yeah. Thanks for bringing that up. I appreciate that.
Yeah, and just to get to the black box warning, because I think that also comes up all the time. And I do think of in a situation where you are in that extreme case of needing to use an antipsychotic for somebody with dementia, you really are almost like at this kind of like palliative care sort of like level of their disease, which is like not too different than giving somebody morphine when they're like in extreme pain. And like morphine has a black box warning too. I mean, like, the risk of mortality from opioids is enormous. But it's not like we kind of like, oh my God, I can't, you're in extreme pain, but I don't want to give you sort of morphine until I've told you this could increase your mortality. And, and there is definitely like that kind of like chronic pain sort of, extremely sort of by the book. Well, you need before you can prescribe this medicine for their pain, you got to tell them that it's like potentially sort of very harmful. And it's like, yes, but when somebody is like screaming in pain in front of you, you're not going to like, wait, stop, black box warning. You're going to give them some opioid to try to relieve their pain. And I really think of using an antipsychotic for extreme behavioral sort of agitation in dementia in that same way. Somebody's screaming in pain in front of you, don't stop and get all bogged down by black box warning. Sort of like relieve their distress, relieve their extreme discomfort and sedate them. And that's just my
Yep. I think too, I mean, just in terms of sedate them, I mean, even if we use the medications at night and patients are getting better sleep, that makes a huge difference, regulating their sleep wake cycles and things like that. So they have, they have other benefits.
Backing on that, can you tell me about how you like your time frame for reevaluation after you've started an antipsychotic? Are you looking at it again at like 2 or 3 months, trying to titrate off again, or do you have a standard for that, or at least in the community?
Yes, that is such a good question. I mean, I do inpatient work. I don't do any outpatient work. So again, would love to hear from my colleagues. What we typically do is, I mean, if we use antipsychotics for anything in the hospital, any kind of psychosis, et cetera, we typically recommend that patients get titrated off, once they're stable over the course of a couple of weeks, at least for kind of delirium. I mean, in the hospital, we're seeing patients every day, to see how the medications are working and to assess things like sleep and appetite and psychosis and behaviors and things like that. Um, but that's a good question with longer term use. I mean, because clearly there's some waxing and waning of behavioral symptoms in dementia. And so, if a patient is hospitalized with acute symptoms, it might be a different situation than if they're in a nursing home and they're not having any risk factors and their behaviors are actually better, where you might not want to continue higher doses of antipsychotic medications. It's also progressive illness. So, unlike some other illnesses that we treat, psychosis from substances or even delirium, you know, the idea is that the behaviors are probably not going to get better. It might get worse over time. And so what do you do with the antipsychotic medications at that point? Yeah, so those are really good questions. And that's actually, it's an excellent question. I don't see outpatients with dementia. And so I don't know how physicians tend to deal with that. I don't know if there's anyone who does.
Anybody want to provide a perspective? Or Trang, from the pharmacist standpoint, any recommendations?
In my
Ye-
experience,
Yes.
I have seen them titrate down if the patient was started on a dose that is maybe higher than the um, normal lower dose, and they were so agitated. So if they titrate it down a little bit, but the patient stays, I don't see patient wean off from this medication like the previous person Barack was talking about. I mean, I see the patient stay on them, even maybe add some more, you know, over time. And so I don't really think there's any titration process. It's all trial and error. And they just keep adding one more because the caregivers will keep, complaining and coming forth with their distress. And the provider tries to mitigate by adding a little bit more, maybe a different one, just kind of playing with it.
Thank you for that. Trang, what were you going to say? And then Brock?
Oh, yes. Well, like Alm's recommendation that we always want to start low and go slow. So for whatever the antipsychotic that we use, we want to use the lowest dose first. And then typically we ask the caregiver or family member to call back within a week if to report symptoms, unless the patient's is worsening. But and also once we find the right dose, a magic dose for the patients, the American Psychiatric Association recommends an attempt to taper antipsychotic within the first 4 months after initiation, for people who have responded to therapy and who have no history of relapse. So even we find the right dose, or at some point the patient is stabilized, and then we can discuss with the family member, do you want to stay on a dose or attempt to taper off? Some patients may not be able to go down to a lower dose. At least if there's a discussion and to discuss the efficacy and then an ongoing treatment. So I would say start low, go slow, and monitor and keep discussing patient and family member, actually with the caregiver and family member.
Very good. Thank you for that. Brock, what would you add? And then I saw Karen and Julie.
Yeah, I think it's a really great question of sort of like, when do you try to taper down? And there's no right answer. And what you're trying to think about is what might have been the transient thing that could have been causing those symptoms that might not be there anymore. And so whether it could be like an adjustment or change in their environment, or whether it could just be the progression of their disease. I think that's like the other sort of really good sort of teaching point, is that people who develop these symptoms in dementia, the symptoms do tend to kind of like diminish as they sort of move into more sort of severe stages of the disease. And so just because they were extremely agitated in the middle of their dementia, it could be that 6 months or a year later, their dementia has progressed or changed in a way that they are no longer going to have those symptoms without the antipsychotic. And so I think, and so deciding when to try a taper is kind of just this like judgment call of when do you think enough time has gone past where either something in their environment or something in their brain has changed enough such that they no longer need it. And so, you can be like err on the side of like trying to get them off quicker, which is going to be like at the 2-month mark, or you can be like more conservatively like afraid to rock the boat and sort of have them lose their sort of place of living again, and sort of like say maybe it'll be more like a year, but like somewhere in between the 2-month and the 12-month, based on your sort of clinical judgment of how much time needs to pass for things to change enough such that they don't no longer need the medication.
Yeah, you reminded me that this is true for behavioral interventions too, that spirit of kind of constantly investigating, is this working? Things that used to work, don't, to things that didn't used to work now might. And, how do you kind of always approach that with the sense of curiosity? It's tough to do. Veronika, I want to give you a chance to respond, and then I'm going to come back to Karen.
Yeah, I was going to say, in addition to the antipsychotics, there is good data for the SSRIs, and frequently a medication like Lexapro or sertraline can help with irritability and depression, and even with psychotic symptoms or with paranoia. And so, they take a lot longer to work. But that's something that, somebody started on sertraline in the hospital, then 4 weeks or 6 weeks down the road, you could potentially decrease the antipsychotic because of the effects of the antidepressant medication. And then I was also going to say, I mean, the antipsychotics are are different depending on which one you use. So if someone was very agitated in the hospital and was on, Zyprexa or Seroquel, and it turns out that it's too sedating on an outpatient basis and the patient really isn't functional, you can always switch to a different antipsychotic. So it's still, you have the antipsychotic effect, but not the sedation or the movement issues, or, you're not putting the patient at risk for falls if they're not in an environment like the hospital where they're watching you so carefully, things like that.
Very good. Karen?
Yeah, my comment was it's not about pharmacology. So if Julie wanted to respond to the pharmacology, maybe she could skip it. No, okay. So as the caregiver perspective, one of the books that really helped me was called Responsive Dementia Care. It's by the Whitworths. The Mr. Whitworth started the Lewy Body Dementia Association after his wife died of dementia, and then his new wife is a nurse specializing in neurology and dementia. So anyway, they wrote this book called Responsive Dementia Care, and I've recommended it to a lot of my friends in my different caregiver communities and support groups, and they all call it their new Bible. It's very short chapters about how to think about how the brain is working, and it's not just for people with Lewy body. They say Lewy body and other dementias, but since Lewy body is kind of famous for behaviors, I think a lot of spouses and caregivers pick that book up. But one thing I'll just say for everybody to think about, and maybe counseling caregivers, is the perspective of someone with dementia, I don't know, moderate, severe, moderate, becoming severe. They tend to absorb, they lose their sense of self as differentiation from other people. And Veronika can correct me if any of my psychiatry is wrong, but they just tend to absorb the emotions that are around them. And so it was revolutionary in my relationship with my husband of when I would feel frustrated or he would feel me being upset about something, even if it wasn't him. Maybe it's something I listened to the news on TV or something, and something made me mad. He would just absorb that, and then he would become that. And then he didn't know why he was feeling that way. And so the first person he saw, he thought it was me making him mad or something like that. So it gets really confused. And I realized that I can control the situation by, if I can't do it honestly, I can do it by acting. And just being really sweet and supportive and gentle and calm, and just stuffing down all those feelings of frustration and why are you doing this again, or oh, we just went over that, and because they suck that up. And I realized, you know what, that's just boomeranging back on me. So it's actually self-care for me to even just pretend. And I did have a couple friends say, oh, it's really sweet how you and Scott are so sweet together as his dementia is advancing. And sometimes I look at them and say, it's all an act. I'm super frustrated right now, but I have to maintain this calm because it keeps him calm. And, you know, I just change when he'd get upset. I just change the subject, like, you know what, you look really good today. You're so handsome. And, you know, you can turn them on a dime if you catch it early enough. If it festers too long, then they're stuck in their psychotic anger, and it takes hours and hours, if not a whole day, to kind of get them out of it behaviorally. And this was all with no medications. I did this for 2 years with no benzos, no, because he was Lewy body, so everything was contraindicated and nobody was prescribing him anything. Eventually he did flip out and went psychotic and was in geropsych for 7 weeks, and came out a zombie. You know, but that was what was appropriate at that time. But I think I still got a couple of good years at home with him by me as the caregiver understanding what was happening. And so when I see other caregivers with that frustration and the barking orders and the repeating, they feel that, and you see it's not working. So I'm trying to be an ambassador with my friends. So I'm just sharing that with all of you, of maybe a little counseling with the caregivers in your clinic room about approaching, even if you need to go scream in another room at somebody else's house just to get your frustrations out. But keeping that calm approach really, I think, is magic.
Thank you for that. Julie?
Yes, and thank you for that, Karen. That was really wonderful recommendation for that book. That kind of ties into just the comment I was going to make, is that there seems to be almost an overwhelming amount of potential resources to direct someone to. I've found that the more I know, the more overwhelming I might be towards my patients and their caregivers on my recommendations. And so and please, anyone interrupt me if they have more interruptions, advice, but I think that when I think about how important the caregiving aspect of it is, I really appreciate those vetted recommendations for like the book. And for caregiver training, though, that was the question I had. If anyone has experience with this, I noticed that some states have mandated dementia care training for dementia care caregivers. I don't believe that's the same in Washington State. People, yes?
Yeah, I was just looking at Lynn and Karen Clay. Those are the two squares I am looking at right now.
And my question would be, what agency or where do they go for that dementia care? I noticed on like the Alzheimer's Association, there's really like just one listed course or exam listed, but is there like a lot of variability, or is there just like one really standard caregiver course? And if anyone has experience on that, does it kind of align with these principles we're talking about?
Erin, did you want to go first?
Why don't you start? And then I'll fill in.
Well, I will say that
areas.
there is something called the dementia specialty training, and it is required of anybody who is taking care of even one person with dementia in an adult family home or assisted living facility. There is a requirement for dementia specialty training. Our state's requirements are actually higher than most states in terms of requirements for training. And that is about an 8-hour training, and there is a core curriculum that is offered, a book. I don't have it right here to show you, but it includes behaviors. But you know, there's a lot to talk about of 8 hours. It's not all about behaviors. It's about dementia itself and what you can expect, realistic expectations, how behaviors play in, how you can set up the environment. So a variety of different things within that 8 hours. And people that want to be trainers need to go through a training. And Allison Schreier, who used to be the Samantha on this call, was a dementia specialty trainer. So she's an example of somebody in the community who got trained in this training and then provides the training out in the community. So there are trainers across the state that are making this available to providers. Now those are facility providers, right? Adult family homes and assisted living facilities. The same training does not apply to nursing homes. They have their own training. So there is training out there, but that said, I think you all know there's a lot of turnover. There's a lot of this stuff that you can be trained on it and not necessarily absorb the personality and the temperament to be able to implement the kind of things that Karen Hayes was just talking about. You really, you hit a point with me, Karen, because one of the things that I have learned over time, because I've done a lot of work with families who are caring for people at home, is, you know, you almost have to get family caregivers into the idea that they can do things about behaviors before they start occurring, right? Before they become really prevalent in their lives. And that's where, when you hear people like Karen Clay or Karen or other people in the community, will always be talking about help people get to support groups, training with the Alzheimer's Association out in the community early, so that they learn the fact that they can make a difference by their approach, by the environment, by the way they speak with them, by the way they don't rush them. You know, there's just all these things you can learn about communication and tips, but you have to do it before you're in a crisis state, because by the time you're by the time you're overwhelmed, you can't take it in and change, right? So there are resources out there. There's some on our Dementia Action Collaborative website. I'll put some tools in the chat. I think Karen Clay might have some other resources to share. But I think that is sort of my thought, is that if we can have those, you guys don't have time in your office, but if early on you guys can start setting the stage for the importance of routine, for the importance of learning, for the importance of, you know, getting out and looking at resources, even if they don't want to, keep trying to get them to go to support groups, use the Alzheimer's Association for getting education, because they can, like Karen says, you can keep them at home for a long time if you learn how to read the cues that they have some need that they're not getting. They're just expressing it through their behaviors. If you can help them understand those tidbits, they might be more likely to go to these trainings. So that would be sort of my thought, is you guys can plant the seeds and then share the resources. And if you guys need help figuring out how to share those resources, we'd love to hear it, because we'd love to support you. And I think Karen probably has more ideas.
Oh yeah, and Lynn, just to piggyback on that, when I think what's interesting about the requirements versus, I think there's a disconnect with the providers, that we have such a prescriptive ability to influence, except when it comes to how caregivers are educated or how they act to our patients. I'm often getting asked to make a, you know, could you write to the facility to walk my family member 3 times a day? And so I sometimes am asked to prescribe things that are out of the realm of medications. And then that's like this gray area of, I'm not sure what their expectations are, what their training already is when it comes to dementia care. And so it would be maybe an interesting conversation to say, well, you're a provider who has a dementia patient in an adult family home. What are the kind of things you can prescribe? What are the kind of recommendations you can make, or what are the if you were to have a conversation with caregivers at a facility, what are the top 3 resources you might, you know, recommend they look into? Yeah, and then of course I want to hear what Karen says.
Yeah. Are you asking me what those top resources are?
Or no, just group in general, community.
Okay, great. Yeah, because I can put a couple in the chat, but I think Karen Clay might have a couple ideas too.
Yeah, just it's such a great topic. And I really appreciate Veronika kind of putting in that sort of like caregiver piece, which Karen Hayes and Lynn is also sort of speaking to. You know, for me, a couple of things that I really think about a lot is it means a lot for medical providers to say, you know, first line interventions are non-pharmaceutical from the beginning, because family members are a lot more open to that if it's the medical provider, the doctor, the advanced practitioner, to really say like, those are the, you know, best scientific evidence behind those. That kind of helps us in the community that are doing that. And then totally agree with Karen and Lynn, like when people are in crisis, when family members are in crisis, like that's not actually the time for them to get a lot of dementia training, right? We want to be sort of like shoring things up, right? When things aren't in crisis, how can you shore things up? You know, I kind of use some framing around like, you know, this is really a condition that requires a village, not an individual. So make sure you're getting respite, kind of build those tools. In addition to the specific things that Lynn mentioned, and Barack, I appreciate that you put information about the powerful tools. Most of your area agency on aging does offer some sort of STAR-C program. training. And that's a really very, very specific dementia support training for folks. It's also something that's offered through Full Life virtually through the Memory Hub, and that's free for people. So sort of encouraging folks to take advantage of that STAR-C or those other like support groups to kind of build up those resources before they need to. Because honestly, I do a lot of like counseling around like people are in crisis, really trying to help them kind of just get down so that they can get a little bit of a break to think more clearly about things.
Excellent. Thank you for the reminder about STAR-C also. That's a great resource. And I know it varies a little bit by county, but I know it's also offered, I believe, in Spanish and a few other languages. So, yeah. Jeff Kaplan, you've had your hand up for a while, then Reza.
Just a little different tact on some of it. Years ago, I read Atul Gawande's book, Being Mortal. And he profiled a nursing home where they gave purpose to residents and found significant improvements in behaviors. I think they brought in pets and birds and things like that. Where is that now? We certainly don't see it in Yakima, but where is the place for that now? And is there further evidence regarding that?
Great question. While people are thinking about the answer, you know, one of our areas of focus here at Memory and Brain Wellness is strength-based approaches, right? And the retained strengths and the retained abilities. And one of those things that is often retained in at least in early stage dementia, maybe mid-stage too, is that need for purpose and meaning and a role and contributing, you know, and to assess someone's past preferences and strengths and abilities and then design things around that. I'm thinking about a gentleman who his family decided, he was a mechanic, and they decided that they were going to have him quote unquote help by sorting a bucket of bolts and screws and washers. And he did that for hours and his agitation levels went way down. I mean, it was non-purposeful behavior to a degree, but it served this greater good purpose. So things like that. Places that do that well, I don't know. I would love to hear it.
I think some of this is Karen Hayes. I think some of the memory care places do it well, not all, from what I've seen and from what I've heard from my dementia caregiver friends. But outside of and then a lot of the adult day places, that's kind of what they're designed to do, is a lot of that, giving purpose to the day. And of course, most of my friends, their husbands will go to the adult day place because they're told, oh, they need a helper. Oh yeah, you're not, they don't think they're like that, but they go because they'll be the helper. And then, of course, they get the benefit of all the things. But I think for the individual family caregivers who are in these individual homes, that needs to be part of the training, part of, I love what Reza said, because giving my husband things to do, you go out and rake this, and he'd rake the leaves and put them in a pile. I'd say, that's great. Now we need to put them over there. Okay. And so then he'd rake some more and put them over there. And he didn't really have an ability to look into the future or to know if the task that he was doing was helping. But if I told him it was helping and I was super praising him, then he was super eager to do it and do a good job and show it off and so forth. So I think that's just an essential piece of training for anyone who's taking care of people with dementia. Have something meaningful in the day that they feel like they've accomplished and they're getting praised, because they soak up praise so much. It really changes their day if they can do something that you can praise them about.
Very good. Very good. Reza.
Yes. Hello. I'm Reza Tabibi. I'm one of the geriatricians at Evergreen Hospital. I was not at the beginning of the lecture, unfortunately, but I just give some ideas. Maybe it's just repeating. Most of the time, we have papers from adult family home assisted living at, I'm just thinking about outpatient, not inpatient, that the patient has anxiety, patient is agitated, so. And so when I look at all of those notes, I notice that the patients Usually they go to their bed at, for example, 6 p.m., 7 p.m. And if you imagine that a geriatric patient has a 6 hours full-time sleeping time, so they wake up after midnight or 2 a.m. and they're agitated at that time. So unfortunately, in many places, including hospitals, even our office, everywhere, a schedule is not based on the patient. It's based on the caregiver, based on the provider, based on the physician. So that should be changed. I don't know how. Don't ask me how, because it's difficult. And imagine that the patient, when they go to hospital at 6 a.m., they come and, hey, wake up. That's the time for a blood draw. And this patient just, was able to go back to bed. So that's a major issue. And I think we can do a lot. We can look at, just observe and find the problem and go and talk to it. That's what I do in my workplace. The other thing is that many caregivers, they just don't introduce themselves. Imagine that you, with this intact brain, you are in a bed and someone comes at 6 a.m. and say, hey, Reza, wake up. And I don't know that person. I'm confused at the beginning of the day. So now we have a person who has dementia and he's in prison of dementia, cannot recall it. So I just ask all of the adult family home, I write the order for them, because if you don't write the order, they don't give a glass of water to the patient. You have to write order that please do this, please do that. So I give them an order that please introduce yourself. Please have a name tag and tell what you are going to do for the patient. And just try to, don't push the patient. If your patient is waking up at 8 a.m., there is no need to give them medication at 6 a.m., wake them up. So I just always tell them that if the patient is sleeping, please don't wake him up. So those type of things that we can do. Other thing is a feeling of safety. I imagine that just one of us being in a room for 24 hours and nobody talks to us and we don't understand what they say, or we are in different planets and we have no idea what's going on there. So that's unfortunately life of the patients with end-stage dementia. And so we need to have the schedule for them. They need to ask them to, everything based on the patient's schedule, not our schedules. And I think that solves many of the problems. Again, it's very hard to do that. It's not easy to apply to the workplace, but it's very hard to do that. I had the opportunity to sit next to Nancy Eisenberg for about 1.5 years when she was coming to Evergreen, and I call her memory queen, basically. And it was a very good experience. At the same time, we had another physician, Jeanette, who was a geropsychiatrist, and I had the opportunity working with her. So I learned a lot from them, and I see myself as their student. For antipsychotic as outpatient, I always ask the patient family members that, do you want to keep this patient sleepy or awake? And based on that, I choose my antipsychotic. If they want him to keep him awake, I talked about Risperdal. If they want to keep him sleepy, I start Seroquel. Sometimes it's ridiculous, but I do it. At nighttime, I give them Seroquel. In the morning, I give them Risperdal. But I discuss the side effects. And of course, you need to look at the patients. If they have Parkinson's disease, you don't give them the Risperdal. So I start with a very low dose. I am not as brave as psychiatrists. They are very high dose sometimes, but we start like a 12.5 milligram Seroquel or half a tablet of 0.25 milligram Risperdal. But I divide the dose. I always ask the family, the patient's family, that what time of the day your husband or what time of the day your patient is getting agitated. Usually I give them a dose 2 hours before that time of agitation and slowly increase the dose. So yeah, that's what I was thinking. The other thing I was going to tell you is that some patient in adult family home assisted living, they don't like some of the caregivers, and exactly opposite, they like other ones. So I did a little bit of research. It goes back to memory distortion. For example, if you have a son who looks like your caregiver and at a younger age, then you like that caregiver. If you have a person who wanted money from you and you remember that when you were 30 years old, so you don't like that person. So that's another thing that in the assisted living adult family home, I always tell them that, for example, I say, who do you like? I say, I like John, for example. I ask them, hey, ask John to spend more time with this patient. I was going back to that point that I said about the patients feel yourself in a room and you're locked there as a prison there, in prison there. You know, that means that feeling of safety. When we feel unsafe, we get more agitated. So sometimes I just tell the family member, just hold his hand and just tell him that I'm here, I'm safe. I write everything with the large letters on a paper and red color. And many of my patients have textbook of my instructions. So I ask them to just hang on a room, for example, that say that you're safe, I'm here, or giving some instruction that they can read that. Sometimes they have dementia, but still they can read. So that was my point. Thank you so much for having this good conversation. I appreciate it.
Oh my goodness. And thank you so much for adding to it. What a wonderful, rich discussion that reminds me that this is something we could probably host many, many, many sessions on. Really wonderful. Thank you, Dr. Zantop, for a great didactic and leading us into this fantastic discussion. Lots of resources in the chat that we will be sure to send out. And again, I think this is always worth revisiting. So may you all be well. I realize we're a couple of minutes over, but definitely worth it. So we'll see you next time.